Hi, I'm Dr. Kimberly Turner, and welcome to Moms, Minds, and Medicine Inside Maternal Health Research. This podcast is your trusted companion on the pregnancy journey, where we break down the latest insights, answer the real questions, and empower you to make informed decisions every step of the way. Welcome to Moms, Minds, and Medicine Inside Maternal Health Research. I'm your host, Dr. Kimberly Turner, a board certified OBGYN, and with us today to discuss some of the implications for mom and baby of gestational diabetes is Dr. Abimbola Aina, who is a maternal fetal medicine subspecialist at Johns Hopkins. So welcome, Dr. Aina. Thank you so much for your time and your talents.
Thank you. Thank you for inviting me.
So in this episode, I wanted to delve into what happens after I've had gestational diabetes to me as a woman. Do I need to worry about that for the rest of my life? Do I need to worry about that when I'm pregnant again? Can you walk us through and tell the viewers what is the risk for the mother after the pregnancy?
So, anyone who's been diagnosed with diabetes during a pregnancy has a higher chance of developing what we call type 2 diabetes outside of
Right.
pregnancy. And so, for the women who were diagnosed in early pregnancy, we talked about timing of when we screen a pregnant woman. If they're diagnosed in early pregnancy, they have a much higher chance of having persistent diabetes when the pregnancy is over. And
Okay.
so, what we do for anyone with gestational diabetes is at their 6-week postpartum checkup, they should have another screening. A lot of
Yeah.
women skip that checkup, and it's not good to. Yes, your blood sugars, we tell you you can go back to eating what you want after delivery. You don't have to check your blood sugars for those 6 weeks after delivery. But once all the hormones have cleared your system, you should go back to normal. And so another
Okay.
glucose screen is our way of proving that you did. And if you at that point have a glucose screen that's abnormal, then we reclassify you as a type 2 diabetic. And so for some women, that risk of being diagnosed with type 2 diabetes is greater. And so again, if you're diagnosed in the early half of pregnancy, that risk is greater. But even if you're diagnosed in the third trimester, your risk of diabetes over the next 20 to 25 years of your life is upwards of 75%. And for some ethnic groups, it is 50% within 5 years. And so if you have had diabetes during a pregnancy, there are things that you could do to try and make that better. All the things we talked about, your diet, exercise, weight loss, to try to reduce that risk of getting the type 2 diabetes diagnosis.
Is there any data or any research going on about why so many of the mothers are resistant? I found that when I was in clinical medicine as well to doing the 6 week. Is it an insurance issue? Is it time? Because now I have a baby and that's a 2-hour test. Any
Yeah.
insight there?
So I think to a certain degree, some women feel that I'm young, I'm healthy, and I'm busy. I've got a newborn. I don't have time. I'm already taking the newborn to all these extra appointments because I'm breastfeeding. I don't have time to go in for a 6-week checkup. And so their own health takes a back seat because of
Unfortunately.
work restrictions, because of baby demands, or because their insurance does run out. There are some women who are only covered for their pregnancy. And then once that coverage expires, if they missed the window to come back in for a postpartum checkup, they're not going to pay out of pocket to do that. And so it's a myriad of reasons, but Um, a lot of women just don't feel it's necessary.
Okay. Is there a quicker test? Can I do? We had another guest that talked about the hemoglobin A1C, which is a blood test that tells how your sugar's been over roughly 3 months prior to the test.
So that is
Is that a valid way? Quicker?
well, it's an option if we don't have the time to do the screening, but the problem with the hemoglobin A1C is that it is an average. And so
Okay.
we could have gotten you into wonderful control at the end of your pregnancy. And then the 6 weeks post pregnancy, you were back to old habits and
Mhm.
eating what you wanted. And then we check an A1, a hemoglobin A1C, like you mentioned. The problem with that is that's going to factor in your excellent control at the end of the
Okay.
pregnancy with the terrible control post pregnancy and potentially gives you a normal result. And so that's not
Oh,
helpful. What we really want to see
sure.
is what is your control now? And in
Okay.
order to get that information, we really want to see how you respond to a fasting or a post meal. And the screening test is the
Okay.
best way to do that because it combines the two. You get a fasting value, a drink, and a blood test 2 hours later. The alternative,
Okay.
since a lot of these women are used to checking their blood sugars, is go back to checking your blood sugars. You
Okay.
have the equipment, test at home, bring those
Right.
values into your provider to analyze. Again, outside of pregnancy, targets are a little different. And so that might help you still be within. So that's something to think about.
Okay.
Okay.
Okay. Interesting. I really did find that, and we still find that, mothers do not always put their health first. So with this public health initiative, I think some of the researchers are working on things like that. Like, how do we make it more accessible, less time consuming? Oh, and just popped into my brain that you said breastfeeding. Does breastfeeding decrease your risk of long-term diabetes or short-term diabetes?
It does not. Yeah, breastfeeding certainly helps regulate your hormones post delivery. But in
Okay.
terms of developing diabetes, whether or not you breastfed, it's not going to truly impact that, not by a significant amount.
Okay. Well, we want mothers to breastfeed for various
Yes.
other health reasons. And the other thing that sort of came to my mind is how if women really knew, and I don't think this information is all that well assimilated in the populations, but if they really knew how important it is to know your pregnancy health for those of us that choose to have babies and how it's kind of a barometer for the rest of your life and how there are things that you can do to decrease your risk of these long-term common disease states. But that would be another episode.
Yeah.
So, but we, as Dr. Ina said, if you've had gestational diabetes, make sure that you check your blood sugar pretty much every year
Yeah.
for up to 20 years.
Yeah.
It sounds like.
Yes. Yes.
All right. So now on to the baby who in our last episode we said sometimes smarter than the mother. What is the long-term risk for the baby in terms of developing diabetes in their life when the mother has had diabetes
So
while pregnant?
exposing baby to a diabetic environment. So for the moms that are um, in less control, their babies are at greater risk of developing diabetes, particularly childhood diabetes, um,
Mhm, mhm.
but certainly later in life. And so for those babies, particularly the ones that um, are born large
Okay.
or have been exposed to poor maternal control, their risk is increased compared to the mom who was in good control and developed a baby that was of normal weight, of normal birth weight.
Okay.
And so it does impact those babies long term.
And I assume then that the pediatricians, of course, they know the birth weight. but they know to kind of follow those babies for a certain period of time. How do we get that information to them if they
So,
weren't part of the delivery?
yeah, oftentimes the pediatrician asks mom how her pregnancy went and if there were any
Hmm.
complications to get information that might impact baby. So it's a little reliant on mom being truthful. Also, it's helpful for the pediatricians who do go evaluate newborns in the hospital, and those are their own
Sure.
patients, and so they get much more information than just relying
Right.
to relay information after the fact. Um, but
Okay.
most of it is going to be just getting the maternal history, um, after delivery.
Okay. I imagine in the larger systems, and we were part of Johns Hopkins, so in the larger systems, it's easier. Everything is computerized, but in small towns, I would imagine that it's harder to have all that information. And again, we are not judging people, but we need to have truthful stories and
Absolutely.
truthful evidence to know what's best for you and your child.
Correct, correct. And to be
Okay.
most proactive. Because if we
Yes.
know your baby's at increased risk, there are things that we can recommend, and I'm sure the pediatricians evaluate for certain things before it can become too much of a problem for the child.
Okay. So some babies have to be delivered before full term. And in my career, the definitions of full term kind of changed. What leads you to need to deliver a baby because of the mom's diabetes?
So, we can deliver babies early for mom's sake or for baby's sake. And so, again, in a mom who's not in the best of control, her risk for developing blood pressure issues goes up. So if the mom
Right.
is having a lot of blood pressure issues, particularly preeclampsia, it may behoove us to get baby out sooner because we know
Hmm.
the only cure there is for preeclampsia is delivery. And so
Right.
for some moms, that might put their baby at risk of an early delivery simply to improve maternal health. For baby, the interventions that we go through is uh, for an early delivery, we will recommend an early delivery for a baby that's in trouble. And by
Okay.
trouble, I mean the baby's not growing. Sometimes, paradoxically, in diabetes,
Mhm.
particularly early stage, early diagnosed diabetes or type 2 diabetes, we can actually get a very small baby. And so, in those
Yeah.
circumstances, sometimes we have to deliver babies sooner. Or the monitoring that we talked about before, where we're keeping an eye on baby's well-being, sometimes the baby gives us signals that it's not doing well, and those are reasons to go early. But ideally, if mom's in control and baby's telling us it's doing okay, our goal is not to go before 37 weeks. 37 weeks of
Right.
pregnancy is considered full term. And so we try not to do anything before that if we can help it. Um,
Sure.
we do know that diabetes, as I mentioned previously, can slow down the lung maturity in a baby. And so sometimes we get these babies who've been exposed to a lot of sugar, and the baby's estimating 10 pounds already at, say, 37 weeks. And the mom says, well,
Mhm.
can't you just get them out? Because I really want a vaginal delivery. Well,
Right.
we know that if her sugars haven't been in the best of control, although that baby is technically full term, that baby's lungs probably are not ready. And so we often do not deliver a baby early simply because of its size. And so what that means is that for the poorly controlled diabetic mom, that's how you hear about babies that are 11 pounds
Mhm.
at delivery, because we know those babies probably don't have adequate lung support yet. And so we can't deliver them early simply because they're big. We have to deliver
Right.
them based on their age and try and push beyond that 37-week mark to get them to a space where hopefully their lungs are ready to be on the outside.
Okay. And most times when we want to deliver the baby, we have the very frank discussion with the mother about the risk and the benefits. One of the risks is that your cesarean section potential increases with an induction. And I guess we need to back that up a little bit and explain induction versus C section, what might lead, other than size,
Mhm.
which, of course, if you have a 12-pound baby, you're more likely to have a C section. What does that look like in terms of counseling for the mother?
So there are lots of things that play into it. So we look at what a mom did previously in a prior pregnancy, if we have that information.
Right.
If they've had a C-section before, they have the option generally of um, having another one or going for a vaginal birth. And so
Okay.
if the baby is of a reasonable size and they desire a vaginal birth, we can do what we call an induction if the mom doesn't go into labor on her own. And basically, the
Okay.
induction means that she receives medicines to put her into labor. Generally, that happens somewhere around 38 to 39 weeks to try and get baby again at least full term, so at least 37 weeks, and then old enough that the lungs are probably ready to be on the outside. And so we go around 39 weeks. We give mom an opportunity to go into labor on her own. And if she does not, then that mom gets offered an induction of labor, come in, receive medicines to put her into labor, and hopefully have a vaginal birth. If the
Right.
mom elects for a C section or the baby, as you mentioned, is too large, meaning in the setting of diabetes, any baby measuring 10.5 pounds or greater, the thought is maybe a C-section would be better for the
Right.
the pair. That's because babies that have diabetic moms tend to put more of their weight in their trunk, so their chest, their shoulders, their abdomen. And in that circumstance, what can sometimes happen is at the time of a vaginal birth, the head delivers normally, and then the baby gets stuck, particularly at the shoulders. And when that happens, there can be nerve damage to the arm. There can be other birth trauma. So sometimes the collarbone breaks, sometimes the arm gets broken in trying to relieve that pressure to get baby out vaginally. And so
Right.
at 10.5 pounds in a diabetic mom, we would offer her a C-section and say, chances of having injury to you or the baby from a vaginal birth are so great that we think a C-section would be better for you. But outside of that, if a patient desires a cesarean because she had one prior, or even electively, some women just do not want to labor.
Mhm.
After appropriate counseling, that is their choice. We would proceed with a C-section.
Okay. Well, thank you. Yes. Inductions can be a little daunting, I think, particularly on your first baby, because they can take more than 24 hours and require quite a lot of support and mental and physical fortitude
Very true.
for the mother.
Yes.
So, one of the things that seems to be new, at least in my mind, that wasn't used as a standard when I was in clinical practice, is the continuous glucose monitor, like the Dexcom. Are those safe to use during pregnancy? Is there such a thing as a person that shouldn't use it during pregnancy?
No, continuous glucose monitors are very helpful in pregnancy. Unfortunately, though, the ability to obtain one is often driven by a patient's insurance coverage. And so some insurance
Mhm.
plans will pay for it during pregnancy and others will not. Certainly for the mom who is having more difficulty controlling their blood sugars, the continuous glucose monitor gives more information about why they may be struggling. And so,
Okay.
what sometimes happens is that because the CGM, as it's called, is
Right.
monitoring constantly, a patient can truly understand what's happening even between meals that might be impacting how she responds to a meal. Sometimes women have very low blood sugar because they're not snackers, for instance, and their blood sugars go quite low between meals. What can happen in that circumstance is your body knows how to protect itself. And so when you
Mhm.
have a low blood sugar, your body actually starts to make its own sugar. And so when you have a low, your body goes into what we call gluconeogenesis, which is just a fancy way of saying sugar producing mode. And so
Right.
it's trying to keep you from passing out from low blood sugar. And so it starts making its
Okay.
own sugar. But around that same time, you get the sense, oh, I'm hungry. And so then you go to eat and you add even more sugar. And then you wonder, I ate the same thing
Oh,
yesterday and my blood sugar was fine. What the CGM then
interesting.
tells us as we interpret that data is, oh, well, you went really low right before that meal, as opposed to, say, the day before when you had that same meal and you were level. You weren't as active that day
Okay.
and you didn't have a low blood sugar going into that meal. And so it gives us a lot more information than just the 4 time points that poking your finger does. But, we still get information from finger sticks, that may be helpful, and, we always try and troubleshoot why a patient is not in the best of control. But we do find that the CGMs are quite helpful, especially for patients on medication, to try to make
Okay.
sure that we have them on correct dosing, to make sure that we're not causing lows, in between meals. And sometimes it's helpful because it's the strongest information we can provide a patient about what they're doing in their daily activities, daily food intake, daily lifestyle, that might be impacting their sugar control.
Great. More information. Information is power. Well, thank you so much again, Dr. Ina. I will just say again, you have a great way of explaining things that makes it very plain. I've learned some things that I didn't know during our conversation, and we would love it if you would come back at another time and we can find another area of your expertise.
Absolutely.